Hello, everyone. Welcome to another session of Zooming through ID. I'm Dr. Gopal, an infectious disease physician practicing in South Florida for over 20 years. I trained at Duke University, and I am practicing in the South Florida area in the Broward facility. I am the APD for the Infectious Disease Fellowship program here. I chair the antibiotic stewardship and am the medical director for infection control. Today we have a very interesting topic, and Jasmine is going to present. She was rounding with me and she was preparing for her boards, and she said, Dr. Gopal, I did see a lot of eye infections. And then she was like, okay, let me see whether I can do a presentation on that. So she picked this topic, and it is a great topic, and she has her presentation. So, Jasmine, you can introduce yourself and what your passion is and what you want to do. And she rounded with me and she was excellent. And I know she wants to go into hematology, oncology, and she's interested in that. So, yeah.
All right, thank you. Yeah, my name is Jasmine Cheatham. I'm originally from Seattle, Washington. I did my medical training at American University of the Caribbean in St. Martin, and now I'm here in Broward doing internal medicine at Broward Health North. So yes, like Dr. Gopal said, I am interested in HEMONC fellowship once I complete my residency, but I'm open, so we'll see what happens. So I'll go ahead and get the presentation started. I'm going to share my screen. Um, Okay. You can see this okay?
Yes.
All right.
Is it
Good.
full screen? Yeah, yeah, I think it is.
Okay.
Perfect.
Okay. So, the title of my presentation is Bacterial and Fungal Endophthalmitis. So we'll go ahead and get started. So, just an overview. Endophthalmitis is a severe intraocular infection of the vitreous and or aqueous humor. So, looking at this image down here, the aqueous humor is the front portion of the eye, and then you have the iris, and then in the back is the vitreous body or vitreous humor. And these structures are just fluid that are in front or in behind the eye, and they provide nourishment as well as maintaining intraocular pressure. The vitreous humor in particular is going to maintain the shape of the eye as well as support the retina. So endophthalmitis is an ophthalmologic emergency with a high risk of permanent vision loss if not treated promptly, and it occurs via two mechanisms, exogenous or endogenous, and we'll touch on those in a second. So moving into the pathophysiology, it is a microbial invasion that overwhelms the ocular immune defenses. And so it's important to identify the category of endophthalmitis as this is going to influence the presentation, the microbiology, and the overall visual outcome for the patient. So if it occurs through exogenous means, it's usually due to post-cataract surgery and an intravitreal injection, such as anti-VEGF injections, which are becoming more popular for patients with macular degeneration. They're going to the clinic getting these injections, and that just increases the risk of getting an infection. Any sort of trauma or something called blood related, which has to do with glaucoma surgery, which we'll touch on in a second. And the other means of getting an infection is through endogenous, and so that'll include a bacterial or fungal infection that has spread through the blood. So this chart kind of gives us some major categories of endophthalmitis. So there's five main categories that are that increase your risk for getting that infection. So the top one would be cataract surgery, and it's about 40 to 80% of all cases of endophthalmitis. And some of the major bugs that are present with this infection include coagulase negative staphylococci, which is about 70% of cases. Staph aureus follows just behind that, and then you have streptococci. Post-injection infections are usually due to coagulase negative staph again, streptococci, and then we start to see bacillus being introduced. Any type of penetrating trauma is going to also include fungal infections. Then we have the blood-related, and so that's seen in patients that are going for glaucoma surgery, and we start to see strep pneumo, Haemophilus, and enterococci. For keratitis-related infections, that's about 10% of all cases. We're going to start to see Aspergillus, Fuciform in about 50% of cases, as well as Staph aureus and Pseudomonas. And then lastly, through the endogenous spread with the bacterial fungal infections, we see Klebsiella, which is really high in East Asian nations. Candida is the most common fungi, and again, Streptococci, Staph aureus, and E. coli. So the likelihood of developing endophthalmitis is going to depend on the host factor, the inoculum size, and pathogen factors. So typically small inocula are cleared by the immune system with no problem. So coagulase negative staph is going to be native to the skin flora as well as mucous membranes. And so if a patient was to go in and get that area, get your conjunctiva cultured, you'll be able to pull out that bacteria. However, because it's such a small amount, it's not going to lead to endophthalmitis. Another factor is that aqueous humor, which is the front portion of the eye, has a constant turnover every 100 minutes. And so that helps clear some of that bacteria that may get there. Um, Something to keep in mind is that the vitreous humor does not regenerate, so any large number of pathogens can overwhelm the host defense and lead to endophthalmitis. So continuing with pathophysiology, we have some pathogenic factors, and that basically affects, what type of treatment moving forward and how bad the infection occurs. So in Klebsiella, which is a really common pathogen that we talked about earlier, has something called hypermucoviscous, and basically it produces a thick viscous capsule, which can be identified by a positive string test. And this is a way for the bug to evade the phagocytosis immune system. So if you were to grow up the Klebsiella and pull it out on a petri dish and use a utensil to dip it in, you'll actually get like strings of bacteria being pulled up from the petri dish. So it's really interesting to look at. Some other factors include membrane damaging toxins such as hemolysins, sphingomyelinases, and phospholipases. And these are found in the pathogen Bacillus. And so the hemolysin allows for pore formation in the cell membranes, and that leads to cell swelling and lysing. The sphingomyelinases and phospholipases break down the cell membrane of the host cell and decreases the integrity of that cell membrane, causing it to break apart as well. The pneumococcal capsule, as well as pneumolysin and autolysin, which is found in strep pneumo. So those, if the bug has that particular factor, it's going to prevent phagocytosis by neutrophils, allow for colonization and for growth. And then lastly, you have biofilms that are found commonly on devices that are implanted into the body, such as glaucoma drainage devices, keratoprosthesis, which are artificial corneas, and possible intraocular lenses. So any type of foreign object going into the body can produce a nidus for infection. So what do we see on clinical presentation? So the most common symptom that patients complain about is decreased vision. That's going to be accompanied by eye pain, redness, and photophobia. And on physical exam, you're going to see something called a hypopyon, and that's this white structure. If you look at the images of the eye, it's like whitish structure that you see within the iris. And so basically, this is just a white layer of blood cells in the anterior chamber, and it's going to cause vitritis. And if you were to do a fundoscopy and take a look, you wouldn't be able to see much of the structures that are behind the iris, such as the retina and the other structures that are located there. So this is typically what you're going to see on clinical presentation. So it's important to be aware of what to look for. So continuing with clinical presentation, majority of these patients in endogenous cases are going to have systemic fever, and it's going to be absent in the exogenous cases. And so bacteria tends to present more acutely, so within days of the inciting factor. So some sort of object that was introduced, like, a piece of wood or something introduced into the eye, that infection and the pain and the redness and the hypopyon are going to show up within days. But fungal presentation is going to be a little bit more subacute, and it's going to show up um, about, days to weeks later after the inciting event. So looking at this image, you're going to see another whitish structure, but it's a little bit more clumpy compared to the picture we saw previously. And so this is what a fungal infection will look like. So for diagnosis, the initial workup is going to be done clinically, and so it's going to be supported by the physical exam. So looking at those features that we just saw previously. And so you're going to obtain vitreous and aqueous cultures. You're going to do a gram stain of those cultures. And then you also want to make sure that you obtain a blood culture for the endogenous disease because you want to make sure that you're treating the underlying infection that might be causing the endophthalmitis. And just a caveat to point out that negative cultures don't necessarily rule out the disease. And so we can use molecular diagnostic techniques to account for this. And lastly, and most importantly, if you don't do anything else, consult ophtho. They're the ones that are going to be obtaining the cultures and, doing the procedure, which we'll talk about in a second. So if the patient presents to an ophthalmologist's office, this can be done in office. So what the ophthalmologist will do is take a sample of the aqueous and vitreous humor. So there's two means to which they can do that. So if you take a look at image A, you can just use a small needle to aspirate some of that fluid from the vitreous humor or the aqueous humor. And then B is a little bit more invasive, and that involves this tool or this utensil called a vitrector, and that's going to remove the vitreous humor, and it makes cuts really quickly. And then also it's accompanied by a cannula, which is going to infuse the a salt solution. So within the vitreous humor it is like a fluid and it needs to be replenished. And like I mentioned previously, it doesn't regenerate like the aqueous humor does. So we need to make sure that we're using that balanced salt solution to replenish what we're taking out. And then also it helps wash the eye. So it's another means of helping the bacteria get rid of the bacteria. So what do you see on gram stain? So you are going to see these pigment granules, and they look fairly similar. They actually look like gram-positive cocci. In a lot of cases, it is mistaken for that. So what you can do is when looking at this underneath the microscope, if you use a fine focus knob, you'll be able to see in image B the pigment granules and how they have like a coppery kind of color. And that'll help let you know that it's not gram-positive cocci. It's actually the pigment granules that came from the iris of the eye when the sample was taken. And oh, one more thing, the cultures are positive in 90% of the specimens that are collected via the vitrectomy. So another means of diagnosis is through PCR. So this is really good in culture negative cases. It's a rapid form of testing and it uses a cutoff threshold for contamination. So basically, if it doesn't reach that threshold, it's unlikely there's an infection. But if it does, then there probably is an infection present. The only caveat with this is that it's available only in research laboratories. So if you're at a really small hospital, everything might have to get sent out. Otherwise, it can be done in-house. So for treatment, for post-operative endophthalmitis, so that includes like, the patients that got the injections or the post-cataract surgery, things of that nature. So you want to make sure that you do intravitreal antibiotics. So that just involves injection of antibiotics directly into the eyeball. And you can use empiric vancomycin, ceftazidime, or amikacin can be given if the patient is allergic to ceftazidime. And then you want to make sure that for antifungal infections that you give voriconazole. You want to avoid amphotericin if you can, just due to the toxicity, but you can also give that if necessary. And most fungal cases are going to require vitrectomy, just the nature of the disease and how long it takes for it to build up. By the time it does build up, it's a lot, and the antibiotics don't necessarily work on their own. So you'll have to go back in, extract some fluid, and add the antibiotics at the same time. And then also for antifungal cases, you want to include a systemic azole, such as fluconazole. And so if it's just a regular case of just regular oh my gosh, vitrectomy is going to be a last option if the first injection didn't work. So, okay. So then moving on to post-traumatic endophthalmitis. So first of all, you want to remove the intraocular foreign object. So if it's a piece of wood that got stuck in there or whatever the case might be, a nail and, construction workers or things like that, remove the foreign object. You want to give them antibiotics injected into the vitreous humor. If the patient doesn't improve, then you're going to give them vitrectomy where you're, removing some of the fluid, replacing it and adding the antibiotics. And then you also want to do topical antibiotics if warranted, and then systemic as well. And then lastly, you want to give the patient a tetanus vaccine if it's been greater than 5 years since their last vaccination. And so one thing to point out that I didn't mention before is that systemic antibiotics alone are not effective, and they should be used as adjuncts to injections. So first line treatment, always, always, always going to be injections directly into the eye. And then in about 4 to 6 weeks is when the patient should start feeling better. It's usually their pain that goes away first, and then it'll be followed by vision. And another point to make is that some antibiotics, such as amikacin, cannot penetrate the blood-brain barrier. So that's why it's important to give the intraocular injections. So continuing treatment, so blood-related endophthalmitis. So during glaucoma surgery, surgeons will intentionally create a defect in the sclera, and that is to relieve the pressure and increase the resorption of the aqueous humor that these patients are experiencing. And so, but what that defect does is it leaves a very thin layer of conjunctiva, and that can increase the risk of getting an infection. So again, these patients are treated very similar to other cases, which is, you're given the intravitreal antibiotics, and if the patient doesn't recover, the vitrectomy. And then our last category is the endogenous endophthalmitis. So patients that have liver abscesses, endocarditis, or UTIs are usually the ones that also get endophthalmitis. It's just commonly associated with it. And so you want to give them some systemic antibiotics for the underlying infection. You want to, so such as, if they have a UTI, you want to make sure they're getting like the Bactrim or the Cipro on top of the ceftazidime if you have to give it. And then if the patient doesn't recover, the vitrectomy again. And then for Candida, which is the most common fungal pathogen, you're going to give the injection into the eye with fluconazole or voriconazole if the Candida is resistant. And then amphotericin B is going to be third option, but it's not preferred due to the toxicity with the antibiotic. So some complications of treatment or just the infection in general is permanent vision loss. And that's why this is considered an emergency. So the quicker that it's treated, the quicker that we can get the antibiotics in, the quicker that we get the gram stain and culture so we can know what we're dealing with, the better chance the patient has at recovering. Could also lead to retinal damage. And so that's the nature of injecting anything into the eye. You could damage the structures around where you're injecting. And then in really, really severe cases, enucleation can occur, which is basically the surgical removal of the entire eyeball. But you're still going to leave the eye muscles and surrounding tissue, and it's usually replaced with an implant. So as you could imagine, that will diminish the quality of life for the patient. So we want to try to avoid that as much as possible. So it's very important that you treat this rather quickly. So for outcomes, there is going to be some vision loss expected, just the nature of the infection. It's affecting the eye, it's covering up the structures that are used for vision. So vision loss is expected. However, a majority of patients recover fully with their vision returning in weeks to months later. And it really depends on the pathogen. So it depends on those factors we talked about, what type of bug, what type of pathogenic factors does that bug carry, and did we identify it in enough time? And then also what other comorbid conditions the patient might be dealing with. So we want to make sure that those are also getting treated too. And so you're going to have poor outcome for cases with virulent pathogens such as enterococci or streptococci. And so yeah, it's very, very important that we identify the pathogen as quickly as possible. So for prevention, currently there's no published randomized controlled trials that show the efficacy of prevention of endophthalmitis. But however, some of the papers I came across were saying that, it's important that, the ophthalmologist uses masks during injections or whoever the surgeon using masks during the injections that when the patient does come in, if there's some sort of penetrating injury, that we're getting them into the OR as quickly as possible. And then in patients that have glaucoma, we want to make sure that they have pneumococcal vaccination before they even get that blood surgery done. So now I have some questions. So I'll read it. A 37-year-old man is brought to the ED with left eye pain after a metal shard entered his eye at work 30 minutes ago. The patient reports pain, tearing, and blurred vision in that eye. He has no medical conditions and takes no medications daily. Blood pressure is 140 over 80, pulse is 115, and respirations are 20. On examination, the patient appears uncomfortable with constant tearing from the left eye. There are no obvious foreign bodies on inspection, but on penlight examination, the left pupil is shaped like a teardrop. Visual acuity is decreased in the left eye. And the question is, which of the following is the best next step in management of this patient? A, emergency ophthalmology consultation. B, fluorescent stain, intravenous steroids. D, MRI of the orbit, or E, tonometry. All right, so I will go to the answer, and the answer is A, emergent ophthalmology consultation. So just going over the explanation. So the patient has what we refer to as the open globe laceration. And so they got a metal shard injury, which led to decreased vision and teardrop pupil. So those are pathognomonic for open globe laceration. You usually see it in patients that are working with high velocity objects such as power tools or explosions. And the teardrop pupil is formed from the iris being pulled toward the direction of the defect. So management includes IV antibiotics, eye shield to protect the eye, and doing a CT scan of the eye. And obviously, you want to consult ophthalmology and you want to get the patient in for surgical repair urgently. So going over the answer explanation. So choice B and E, fluorescent stain and tonometry are actually contraindicated because they increase the risk of globe rupture slash extrusion. Choice C, IV steroids treat optic neuritis, not open globe laceration. And choice D, which was the MRI, is contraindicated because the patient had a metal injury. So we want to use a CT instead. Next question. A 63-year-old man with a history of local regionally advanced squamous cell carcinoma of the oral pharynx is admitted to the hospital due to cancer-related pain of mouth and throat. The pain has slowly worsened over the last several days and has limited his ability to eat and drink. The patient has felt weak and believes he is dehydrated. He was diagnosed with cancer 4 months ago and has received several cycles of chemotherapy and radiation, and the last of which occurred a week ago. The patient has been told that his tumor is unresectable. On admission, temperature is 97 degrees Fahrenheit, blood pressure is 105 over 60, pulse is 108, and respirations are 12. BMI is 17. Physical exam shows periorbital wasting, dry mucous membranes, and sloughing of the oral mucosa. Absolute neutrophil count is 350, so he's neutropenic. The patient is admitted to medical floor and given IV analgesics. Total parenteral nutrition is initiated via a central venous catheter. On day 7 of hospitalization, he has a temperature of 102.4 and new right eye pain and light sensitivity. Right eye visual acuity is decreased with a clear cornea and anterior chamber. Fundoscopic examination reveals vitreous haze and several large glistening off-white chorioretinal lesions with indistinct borders. Hint, hint. What is the most likely cause of this patient's ocular symptoms? So we have cryptococcus, disseminated mycobacterium avium complex, infective endocarditis, invasive candidiasis, and ocular herpes simplex. And so the answer is invasive candidiasis. So this patient is immunocompromised, so that is a should be a red flag in your mind that it's Candida, and so that basically puts them at high risk. And so patients present with floaters, decreased visual acuity, and late eye pain because it has more of, like I said, an indolent course. It takes its time. It worsens weeks to months later, and fluffy white yellow chorioretinal lesions, and so. Cryptococcus is incorrect because it causes meningoencephalitis and advanced AIDS. It's not really seen in chemo-induced neutropenia. Disseminated MAC is also seen in AIDS, and it's very rare to have the ocular disease. Infective endocarditis is going to give you retinal septic emboli, which lead to raw spots, which are hemorrhages rather than the fluffy white chorioretinal lesions. And then ocular HSV is going to have epithelial keratitis with branching corneal lesions. Again, not the fluffy white lesions that we see in fungal infections. And then last question is part two to that, to the other question we just saw. So urgent ophthalmologic consultation is obtained. Which of the following is the best initial therapy for this patient? And I said this earlier, so the correct answer is E, voriconazole. So, for treatment, you want to give systemic fungal therapy, so fluconazole or voriconazole. You want to make sure that you give them intravitreal antifungal injections, so either amphotericin B or voriconazole plus the vitrectomy. And that vitrectomy is going to remove the fungal microabscesses that are not able to be cured by systemic therapy. So acyclovir is going to treat herpes, not Candida. Capsofungin treats candidemia, but it does not penetrate the vitreous humor. Clathromycin and rifabutin treat MAC, but not antifungal infections. And vancomycin and gentamicin treat bacteria, so it would not work for Candida. So in summary, ophthalmitis is an ophthalmic emergency. So rapid treatment is required to prevent permanent vision loss, excuse me. You have two mechanisms by which the infection occurs. So it's either exogenous or endogenous. And the presentation involves acute vision eye loss, plus or minus eye pain, the hypopyon, which is that white structure we saw in front of the iris, and then intraocular inflammation on fundoscopy. The diagnosis is clinical, and you're going to take aqueous and vitreous cultures and use PCR if the cultures come back negative, and the prognosis depends on the pathogen. So healing depends on the pathogen, when the patient presented, what other comorbid conditions they have, any other underlying infections, and also make sure that we're treating them with the right antibiotics. So that concludes my presentation.
Okay, that is wonderful. This was a great job.
Thank you.
Yeah, I think it's very thorough and, you did excellent job in presenting. Just some, in general, I will end up with some buzzwords that you should be thinking in terms of the boards. There may be a question about a syphilis patient. If it is ocular syphilis, always you have to treat with IV penicillin. Um, if you get a CD4 below 50 patient, and if there is eye involvement, you have to be thinking about CMV retinitis. And there is a classic uh, picture for that. The and then, if you get a DKA patient, always think about mucormycosis, and that's very important. And then the not that common, onchocerciasis that causes river blindness. That's, ivermectin is the treatment. Those are kind of very rare. Then a canthamoeba can cause, eye involvement. That is freshwater exposure. Then you always have to be thinking about gonococcal conjunctivitis, adenovirus conjunctivitis, in terms of the viral. And then, those are some of the eye and infectious disease kind of thing. And toxo, head, that also is important to be thinking about eye involvement. So, okay, wonderful. Good job.
Great, thank you. This was fun. I'm glad to do it.
Yes, yes. Okay, I will see you later in the hospital during
Right
rounds. Okay,
here. Bye-bye.
bye.
Thank you. Bye.
Thank you.